Hi, I'm Allison Curry, and today I'm going to be talking about lung and heart transplantations. So, a lung and heart transplant is basically exactly what it sounds like. They happen when a patient can no longer survive with the heart or lungs that they have, so they need a foreign organ from a donor. And then they basically just come, switch it out with the diseased organ, and get a new functioning one. So, some of the main reasons for why someone might need a lung transplant are just any typical lung diseases such as cystic fibrosis, pulmonary hypertension, any form of chronic obstructive pulmonary disease, cancer that is metastasized, or just any interstitial lung disease. Okay. And there are many reasons for why someone might need a heart transplant, but the main ones include congestive heart failure, dilated cardiomyopathy, heart valve diseases, if you're born with a heart defect, or just arrhythmias which happen when your heart beats in an irregular rhythm. So the lung transplant procedure is a lot more in depth than this, but this is just kind of a simple overview of the procedure. So it starts off with the surgeon making an incision across the chest or even under the arms, and then they will cut off all the airways and blood vessels from the diseased or to the diseased lung so that they can remove it and then bring in the new healthy one. And then they connect the new lung back to the airways and blood vessels to the rest of the body, and then basically just finish up by closing the incision. So, a heart transplant, there are two ways to go about it. There is the orthotopic and heterotopic approach. So, the orthotopic approach is more common, and that's more similar to a lung transplant because it replaces the recipient's heart with the donor heart. And once the old heart is removed, the patient is put on a bypass machine, and they do that just to oxygenate the blood, and then the donor heart is then put in place. And just like the lung transplant, you close the incision and everything's done. Now, the heterotopic approach is just a little bit different. So for the heterotopic approach, the old diseased heart actually is kept in the body, and the new heart is connected to the old one, and it just kind of sits in the right side of the chest. And this is more common for people who have a little bit more function in their diseased heart. It wouldn't work for someone who has very little function in their heart that they have now. And the reason they do this is because both hearts can work together, and the new heart can act as kind of an aid if any complications were to occur. All right, and just like any form of surgery, there are risks that come along with a heart or lung transplant. And the most common, but unfortunately most fatal, is primary graft dysfunction. And this occurs in around 10 to 25% of post-transplant recipients. And it's basically just a type of injury to the new organ that presents itself within the first 72 hours of the transplant. So it does add to the pre-mortality or early mortality rates. And then another risk is the new donor organ being rejected. And I am going to touch on this a little bit more, but your organ needs to match your donor organ needs to match you. So the right size, the right blood type and everything. And even if it does match, the bottom line is that you are putting a foreign organ into your body. So there's a huge chance that it'll just get rejected. And then the last risk is side effects from the immunosuppressants themselves, which is the medication you're put on after you get a transplant. And that just includes like kidney damage, increased risk for cancer, and then obviously immunosuppressants decrease your ability to fight infection. Okay, so with a transplant, you can't just accept any donor organ. You have to look out for some things, and some of them include making sure the organ is the appropriate size and that it fits in the body. I think the next thing, the most important thing, is making sure that the blood matches. Other things you need to consider are just like the patient's height and weight and other medical factors. Just because a transplant is a huge surgery, a major surgery, you just need to make sure that they're well enough to actually go through with it. And then the last thing you need to be mindful of is the transport and preservation time, just because there's such a small window for the organ to actually be viable still. So you can't, for example, we most likely can't take a donor from like California. Okay. And as I mentioned in the previous slide, the organ needs to match. And the way they go about this is the recipient starts out by getting placed on a medical database. And as soon as they are accepted as a transplant patient, basically they get accepted when they recognize that it's urgent enough and the disease has progressed enough to need a transplant. But then after that, the donor also, not after that, this kind of happens simultaneously. The donor is put in a database once consent is given. And then using that information, UNOS runs it through a database and determines who gets what organ by best fit. Like I said before, just the most urgent cases are highest on the list. And then finally, once a match is found, the hospital has between 4 to 6 hours to preserve and transport the organ for the actual transplantation itself. So this is just some of the statistics of survival rates for both the transplants. So over 80% of heart transplant and around 65% of lung transplant recipients survive past the first 3 years. And then around 50% of both transplant recipients survive past 5 years. Obviously, after you get a transplant, you're not just going to be fine and dandy. You are going to need to be on medications, which are immunosuppressants, for the rest of your life, but you can still live seemingly normal life, and you can still exercise as long as you consult with your doctor regularly, making sure you're still healthy enough. So this is just a case study I have for a heart transplant, and it is a 40-year-old male with an enlarged heart and arrhythmia. And then he was taking calcium channel blockers for years to help combat it, the large heart and arrhythmia. But he eventually developed left-sided congestive heart failure, which is damage to the left ventricle and can cause a fluid buildup in the lungs. So that's pretty urgent. He was on a ventricular assistance device until he eventually received a heart transplant after being in the hospital for a while. So because of his congestive heart failure, he's considered high risk. And he does have goals. So his reasoning and goals for exercising are just so that he can get the most out of his transplant and live the most healthy and normal lifestyle that he can. And as I mentioned before, since he is a transplant recipient, he is on immunosuppressants. So we do need to be mindful of that. But that being said, exercise helps immensely when you're on immunosuppressants, just because exercise boosts the immune system. And we need all the help we can get with fighting diseases. So some of the just general modifications I want him doing post-transplant are decreasing the intensity of his workout. So either decreasing the weight, the number of repetitions, the duration of the exercise, etc. Another thing I'd like him to do is adding assistance. So just a small example, if you, instead of doing regular push-ups, you can do push-ups on your knees. And when you're exercising with a post-transplant recipient, it is crucial that you only progress when they're ready. These patients are very vulnerable, and since they are on immunosuppressants and had a huge transplant, they need to progress a lot slower than an inherently healthy individual. And then some of the precautions I would like him to look out for when exercising are like major bleeding, any infections, hemodynamic instability, which is a big one. And that's basically just an abnormal or unstable blood pressure, and just severe agitation. So before a transplant, some of the most common exercise testing include a 6-minute walk test with oximetry. That's just to measure the oxygen levels in the blood when you're exercising. And I would also have him do a Bruce protocol treadmill test. However, post-transplant exercise testing, I would have him do cardiopulmonary exercise testing. And that's just a wide variety of tests done to assess the performance of the heart and lungs during exercise and also while they're at rest. And then one of the most common forms of CPE testing is spirometry. And that just measures things, including to, but not limited to, anaerobic threshold, breathing reserve, arterial oxygen concentration, cardiac output, stroke volume, and carbon dioxide output. So based off the testing, I have an exercise prescription. And since the patient has no other medical concerns besides the transplant for congestive heart failure, and the only medications he's on are immunosuppressants, I have comprised an exercise prescription to help him reach his goals. So this just consists of 3 to 5 days a week of aerobic training for 20 to 30 minutes a day of walking or cycling. And I would like him to do that up to 50 to 80% of his heart rate reserve. And then for resistance training, I have him doing 2 to 3 days a week of arm and leg exercises. And with early post-transplant, I would avoid having him do abdominal exercises. But I do have him doing 1 to 3 sets of 8 to 12 reps of 50 to 60% of his 1RM for his lower body. But for his upper body, I only have him doing 30 to 50% of his 1RM. And then lastly, for flexibility, I just have him doing 3 to 5 days a week of stretching of his major muscle groups in his upper and lower body. And then just holding that stretch until there's a slight discomfort or tension. And then doing that for around 10 to 30 seconds, 2 to 4 times each. So after working with him for a while, I obviously want him to progress. So for aerobic training, I will start by increasing the time, and then I'll raise the intensity and eventually add an incline after. And this is all done when he's ready. I don't have a set timeline for it. But yeah, and then other things like increasing the resistance on the bike. And then I would like to up the intensity, doing little things like 30 to 60 second bouts of running with walking for 20 to 30 minutes total. And then for resistance training progression, I would start him with sit to stands in the very beginning, and then I would eventually progress to squats with hand weights. These are just some examples. And then increase the weight weekly as tolerated by him though. I'd guess like typically around like half a kilogram per week, so definitely taking it really slow. And then I would eventually like to progress to like ankle weights or hand weights in his body weight exercises, such as like stair climbing or anything. And then lastly, for flexibility, that basically stays the same. I think you just progress by continuing to hold the stretch to slight discomfort or tension. But I would still avoid having him do chest expansion exercises just because there is a high risk for sternal instability. Okay, so that's all for the progressions. And then the main takeaway I want you guys to get out of this presentation is that even though transplants can seem really intimidating and may seem like they can hold you back for the rest of your life, that's not necessarily the case. Successful transplant recipients can live relatively normal lives with exercising, although they probably won't get up to the intensity that they want. Exercise is still really important and beneficial. And then, like I said this before, it boosts your immune system, so it can help combat the side effects of the immunosuppressants that they decrease your ability to fight diseases. All right, and then those are just my references.